Good afternoon. I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important discussion on the impact of consolidation on healthcare delivery, access, and cost. This webinar is part of NIHCM's Affordability Roadmap webinar series, where we are sharing research and expert perspectives on the drivers of rising healthcare costs to spur solutions to our nation's healthcare affordability crisis. Previous webinars have covered private equity, the impact of rising drug costs and aging on federal spending, and value-based care. We also have a broader portfolio of work on these topics, including research and journalism grants, research briefs, and infographics. Today, we will hear from a prestigious panel of experts to learn more about the research on the impact of hospital consolidation, the role of the Federal Trade Commission, and efforts to ensure access to affordable and equitable healthcare. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers along with today's agenda and copies of their slides on our website. Closed captioning information for today's event can also be found on our website as well as in the webinar chat. We also invite you to join the conversation on social media using the hashtag Hospital Consolidation webinar. I am now pleased to introduce our first speaker, Zach Cooper. Zach is an Associate Professor of Public Health and Associate Professor of Economics at Yale University. As a professor in public health and economics, Zach has produced academic work on the topic areas of competition in hospital insurance markets, surprise out-of-network billing, and the influence of electoral politics on healthcare spending growth. Zach's work has been featured in the Quarterly Journal of Economics and the New England Journal of Medicine. Zach has also presented his research at the White House, the Department of Justice, the Federal Trade Commission, and the Department of Health and Human Services. NIHCM is also proud to have supported some of Zach's research through our grant program. We're so grateful he's with us today to share some of his research. Zach?
Terrific. All right. Well, thanks so much, Catherine. I'm thrilled to be here. And what I want to do today is start by thinking about why do we care about hospital markets? Then I want to talk a little bit about how hospital markets are functioning, some of the trends we're seeing in consolidation. And then I want to talk about what the academic literature shows on the impact of consolidation. And I'll finish a little bit with some discussion of policy and what the options are at our disposal. So, let's just take a step back. It's really important to remember that the hospital sector is an enormous share of GDP, right? It's 6% of the entire economy. And so when we think about what's driving health spending or what contributes to health spending, it's the hospital sector, right? That's the largest single unitary chunk of the health spend. Often I think there's a lot of focus on PBMs or on cost of prescription drugs, and no doubt those are important to look at. The hospital sector is sort of where it's at. That's the big chunk of spending in the system. It's why it's really the focus of my research. We rely on competition in hospital markets to make them function, right? It's really the backbone of the sort of incentives we create for the hospital sector. So in traditional Medicare, we rely on hospitals to compete with one another to drive up quality, right? And the idea here is prices are regulated. Individuals can choose where they go, and that allows hospitals to compete on non-price aspects of care. Medicare Advantage, we're going to have competition, albeit somewhat constrained, over prices and quality. And then in the private insurance space, we're going to have competition between hospitals over price and quality. So they're going to compete on price and quality to join contracts with insurers. And there we're going to think about these negotiated prices that hospitals negotiate with insurance companies as a sort of a part of their ability to join insurers' networks. So it's worth taking a step back and saying the markets in the healthcare sector are increasingly consolidated. So for context, The Federal Trade Commission, the DOJ, say, look, markets with a Herfindahl-Hirschman index, an HHI of over 2,500 points is highly concentrated, something where we should really pay attention. Most of the healthcare industry has an HHI over 2,500 points. You can see the average HHI in the US hospital sector is sort of north of about 5,000. 90% of hospital markets are highly concentrated, but we're also seeing concentration high and going up among physicians and also among insurers. Now, the hospital sector has really experienced a pretty significant amount of consolidation over the last 2 decades. So this is a graph, some of the work we've done looking from 2002 to 2017, and there have been north of 1,000 mergers between hospitals. And during that period, there have been pretty few enforcement actions, so 11 by the Federal Trade Commission. And that really follows a period where in the late 90s and early 2000s, the FTC really didn't do many cases, in part because they lost a number of cases in a row. Now they're starting to win cases, but they're really, in my view, going after the most extreme of the mergers. And that's partly because it's hard to win these cases. As I'll talk about later, I think it's partly because the agency itself is doing really well, but they're quite underfunded. Beyond that, one of the challenges is that the Hart-Scott-Rodino Act requires merging parties to notify the government if the deals are of a certain value. Turns out that the majority of hospital mergers are actually under Hart-Scott-Rodino reporting threshold. So I think that the FTC sees them, but there isn't the notification that you'd see in a lot of the big transactions across the economy. So the hospital sector is a big share of the economy. It's the largest single chunk of health spending. The market's concentrated. It's gotten more concentrated because of mergers and acquisitions. And if we look at data from the Bureau of Labor Statistics that looks at prices across industries in the US, we see that prices in the healthcare sector are growing faster than prices in other sectors on average of the economy, and that hospital prices have grown faster than prices in any other sector, even after the Bureau of Labor Statistics attempts to adjust for quality. And the question here is this correlation or causation with a bunch of the consolidation that's happened across the industry? So what we can do is say, well, what is the evidence we have? And I want to think about the evidence on hospital prices and clinical quality, hospital mergers and prices, and then hospital mergers and quality itself. So it turns out measuring the relationship between hospital quality and hospital prices is actually really tough, because it turns out sicker patients in all likelihood like to go to higher priced hospitals. And so I have some work with John Gruber and John Graves, Joe Doyle at MIT, trying to get at this by exploiting the fact that ambulance companies have really strong preferences about where they transport their patients. And so we can build this sort of fancy identification strategy to get the causal effect of going to a high-priced hospital. And our results really surprised me. What we found was that going to a high-priced hospital gets you better outcomes. Right? I was not expecting to see that. And the effects here are really, really big. So moving from the 20th to 80th percentile in prices raises spending on an inpatient admission by about 53%, but it's going to lower mortality by about 37%. Those high prices are going to be cost effective, right? Because they really do have an effect on lowering mortality. But here's what's really, really important. This relationship between prices and quality is only present in markets where there's competition. So if you're in a hospital market where the HHI is 5,000 points, we don't find any relationship between high prices and quality. In those markets, when you go to a high-priced hospital, you just spend more on your care and don't get better outcomes, right? So here, what we're seeing is competition is mediating this relationship between hospital prices and quality. That is, that markets can function in the healthcare sector, conditional on there being competition. So, what about mergers and prices? So the first thing that I think is really, really important to point out is that mergers need to be reviewed on a case-by-case basis, right? We can't just say mergers are good or mergers are bad, and anybody who says that, you just shouldn't listen to. What we can see, however, is that there's a large literature that shows hospital mergers between parties that are close substitutes, that are rivals, can lead to price increases. And so I have work showing that broadly, the closer hospitals are to one another that merge, the bigger the price increases that those mergers generate. We're seeing mergers between for-profits and nonprofits, nonprofits and other nonprofits, and for-profits and other for-profits, all lead to price increases. So it is not true that when nonprofits merge, they somehow sort of step back and say, oh, we're not going to raise our prices. They do, just like for-profits merging. The other thing to keep in mind is that some individual transactions can have very, very large price increases. So Bob Town, who's down at University of Texas, Gautam Gaurasankaran, and Aviv Nebo, who's now actually at the FTC, looked at a proposed merger between Inova and Prince William Hospital. They are predicting that that merger would have raised prices by north of 30%. And we see in our data price increases of certain transactions that are extremely large. There's also a growing literature by Limor Daphne, Kate Ho, and Robin Lee, and some others looking at so-called cross-market mergers. Now, I don't think the name here is totally right. I don't think these are cross-market. I think it's just that the market's really, really big in some cases, and that these mergers can lead to 7 to 10% price increases. And basically, it's these mergers between hospitals that are pretty far apart can raise prices if those facilities share a common insurer. So, what about mergers, quality, and efficiency? So there's a little bit of research on hospital mergers and efficiencies that finds that acquired hospitals can actually reduce their costs by somewhere in the neighborhood of 4 to 7%. However, and this is really, really important, those efficiency gains only come from mergers where the merging parties aren't close competitors, right? So these mergers of hospitals that are 10, 15 miles apart, we don't see any evidence in the academic literature that those mergers are leading to either quality gains or to efficiency improvements. So what about the literature on mergers and quality? I think first it's really important to point out there is literally no academic evidence that I'm aware of that mergers lead the merging parties to raise quality. And so for all of the discussion about this, my sense is if there was something here, somebody would have found it. There have just been studies after studies that have tried to look at this, and nobody's really found anything convincing that when two hospitals merge, their quality goes up. So there's really good work by Limor Daphne and colleagues in the New England Journal of Medicine to find no systematic changes in mortality. There's been some work looking at the Evanston Northwestern Highland Park merger that found some evidence of quality reductions on some measures, and then there's been work by Corey Capps and others that's found some modest evidence potentially of mortality increases post-merger. My sense is, to sort of give a summary of the literature, hospital mergers certainly don't improve quality, and there's some evidence that you can see quality reductions. Where there's very, very clear evidence is that hospitals that are more exposed to competition have higher quality, and that exposing hospitals to competition leads to lower mortality. So that's based on work that Mark McClellan and Dan Kessler have done, and some work that I've done and Marty Gaynor has done. The other thing we're seeing is sort of the opposite of monopoly power, it's monopsony power. So we're seeing that when hospitals merge together, that allows them to negotiate lower wages with nurses. And so that's work by Ellie Prager and Matt Schmidt. I'm just going to wind down here. So what can we do then from a policy perspective? So the first is I think we really need to think about stronger antitrust enforcement. So President Biden issued an executive order, gosh, about a year ago on this. I think it was really important to say that. My sense, and I think by most accounts, the FTC is underfunded. I think we really can and should hope for more funding for the agency. I think they're vital in guaranteeing that we avoid transactions that lessen competition. The second is, in some ways, the FTC has its hands tied a bit when they come to looking at hospital mergers and anti-competitive action. So the FTC and the FTC Act don't allow the agency to take action against anti-competitive conduct of nonprofits. So they can look at nonprofit hospitals merging. They can't go after cases for anti-competitive conduct among nonprofits. And I think that needs to change. There's also been some discussion of folks who look at antitrust broadly, thinking about antitrust statutes. So right now, the plaintiffs have to show likely harm to competition. And that's a really, really high standard. And you might think that there are ways we can sort of change the burden of proof, potentially to amending our laws to say that transactions pose an appreciable risk to competition. And from what I understand from attorneys, that's something that we think could meaningfully change things. The FTC has also put out some really good recommendations and proposals to change the reporting requirements to mergers so that more of these deals that are under Hart-Scott-Rodino threshold do actually have to notify the agencies. Taking a step back, okay, antitrust enforcement's good, but there have been a lot of mergers. Most of the market actually is already consolidated, and this big sort of question is, how do you unscramble eggs, right? It's actually really, really hard to unwind mergers. And so I think what we're starting to see is states take action and introduce different forms of price regulation. We see that happening in Oregon and Rhode Island. I think it's great that states are trying. I think we need to study what they're doing and what effects they're having really, really closely, and think about the extent to which price regulation can be something that's effective in markets where there isn't scope for actual competition to maintain market determined rates. So with that, I'll turn it over to back to Catherine.
Thank you, Zach, for sharing the impacts of consolidation and helping us understand the impact on price and quality. Next, we will hear from Rahul Rao. Rahul serves as the Deputy Director of the Federal Trade Commission's Bureau of Competition. Rahul oversees a team of 300 attorneys and support staff that uphold federal antitrust laws. As the Deputy Director, he assists the FTC with conducting merger reviews, anti-competitive conduct investigations, and antitrust litigation. Rahul regularly testifies before Congress and speaks at panels and workshops. And we're so honored to have him with us today to help us understand the FTC's role.
Well, thank you, Catherine. Can you hear me okay? I just want to make sure. Well, thank you, Catherine. Thanks for inviting me here. I want to start with just a simple disclaimer. I want to note that I am speaking on behalf of myself and not the Federal Trade Commission. My comments today don't necessarily reflect the views of the commissioner or any individual commissioner. So we have a really interesting discussion today on hospital consolidation. Now, consolidation as a general matter is happening across the country in all sorts of industries. Too often we are seeing companies not necessarily focused on improving their products or bettering their services, but rather focused on getting bigger for the sake of getting bigger. Because the bigger they are, the more they can crowd out or outmuscle the competition, and the easier it is for them to raise rates, cut corners, or simply do whatever they need to do to eke out a little bit more profit. Now, as I said, this is happening across all industries across the country, and antitrust enforcers are focused on harm in all markets. But healthcare is unique and healthcare is different. In healthcare, we are quite literally dealing with life and death stakes. So for us, healthcare markets are some of the most important markets for us to protect. In the US federal system, we have two antitrust law enforcers who review mergers, the FTC and the Department of Justice. Our jurisdictions overlap and we enforce mostly the same laws, but it's the FTC that traditionally handles most healthcare provider mergers. The principal statute that applies to mergers is the Clayton Act. Section 7 of that law prohibits mergers that may substantially lessen competition or tend to create a monopoly. The focus on competition is our North Star when we review mergers. And so what do we mean when we say competition? I mean, simply, it's the rivalry that exists among firms that engage in any form of economic activity. That rivalry can be motivated by a desire to sell a product or a service, to buy a product or a service, or to hire the best workers. Competition, to sell, to buy, to hire, it has many benefits. When companies compete to win customers or patients, they're motivated to offer lower prices, better quality, better services. They're motivated to innovate new and improved products. Similarly, when they compete to hire workers like nurses, they're motivated to offer higher wages, better benefits, and improved working conditions. We focus on competition when we review mergers because there is real harm if a merger eliminates an important source of rivalry in a marketplace and thus reduces the motivation to offer better prices, wages, or products or services. Now, there are many different types of transactions that can raise concerns. I'm going to highlight two really broadly applicable fact patterns, but this is not an exhaustive list. The first, and I think the one that most people are familiar with, are mergers between head-to-head competitors. These types of mergers can raise alarm bells for antitrust enforcers, particularly when they are significant competitors in a particular area, and especially when there are few alternatives to the merging firms. One straightforward way that agencies and courts evaluate this is by looking at metrics for market shares and market concentration. Put simply, if the merger results in a firm or a hospital system having significant market share and there are few remaining competitors, or if the remaining competitors are pretty insignificant, that's going to draw our scrutiny. We're also concerned about other types of transactions. You may be familiar with so-called vertical mergers. These transactions involve parties that don't offer the same goods or services. Rather, one merging party offers something that the other merging party uses in their business. So a really simple example is a car manufacturer uses steel to build cars. If a car company buys a steel producer, that's a vertical transaction. In the healthcare context, a vertical transaction could be something like a hospital system purchasing medical groups or an insurance company acquiring a provider. While the merging parties themselves aren't direct rivals, an insurance company is not competing with the provider group, vertical mergers can also harm competition. Going back to the insurer example, if a large insurer buys a major medical group in a specific community, it can charge rival insurers higher prices for the medical group services, or may prevent rival insurers from contracting with the medical group altogether. This in turn may force rival insurers to charge higher prices or to offer inferior health plans or to exit the market entirely. Now, those are just two species of mergers that may be problematic, but regardless of the type of merger, whether it's horizontal, whether it's vertical, or whether it's some other orientation, when we evaluate any transaction, our focus is really on what the law prevents, which are transactions that may substantially lessen competition or tend to create a monopoly. Now, how we evaluate that is both a backward and forward-looking exercise. When we do merger review, we're necessarily making predictions about the future effects of a merger, but we don't do that in a vacuum. We look to see how the merging parties compete in the marketplace today and ask how the merger will change their incentives or their ability to compete. And here, past is often really prologue. The fact that merging parties compete strongly with each other is a strong indicator that the merger will substantially lessen competition. So when we investigate a merger in the healthcare industry, let's say between two hospitals, we ask ourselves a series of questions. Are the merging hospitals important alternatives for patients? What other options are available to patients? Are there other hospitals that are equally attractive for patients? Would patients be willing or likely to turn to other hospitals if they're not happy after the merger? Are the merging hospitals competing to attract patients through improved quality, developing new service lines, adopting new technology, increasing access, or making capital investments to increase capacity? And would the merged hospital system have the same motivation to undertake those efforts after the merger? And also after the merger, will the hospital have a significant market share? And if so, will they be able to demand higher rates from health insurers? Would insurers have to accept those rates because the newly merged system is too important to exclude from their network? Those are some of the questions we ask. And oftentimes, to rebut the answers to those questions, merging hospitals will often claim that their merger will have some significant benefits. When faced with these claims of supposed benefits, we ask, what evidence is there? What evidence is there that the benefits will actually occur? Are the benefits speculative? And could those benefits be achieved through some other way that does not involve a merger that eliminates a competitor? And you heard me mention this before, we also look at a merger's effect on workers. And here the questions we ask are fundamentally the same. Are the merging parties important alternatives for workers like nurses? Are they competing to attract those workers with better wages, better benefits, or better working conditions? And what are the other options available to those workers? How similar are the other potential employers? What's the geographic radius that these workers are willing to travel for a different job? Ultimately, is the competition for these workers important enough that they would be substantially worse off after the merger? Now, reviewing mergers is a critical part of our authority, but our principal enforcement power is our ability to sue to block or unwind mergers. So after an investigation, if we believe that a merger is anti-competitive, we file a lawsuit before a federal district court or an administrative law judge to challenge the legality of the merger. And we don't always do this alone. We frequently work closely with state attorneys general, especially in the healthcare context. Healthcare is inherently local and central to our communities. So working with our state law enforcement partners is something we value when it's possible. And so you will often see state AGs join our lawsuits to block a hospital merger. Now, talking about our lawsuit, you heard Zach mention this in the past session. For the past 2 decades, the FTC has a pretty solid track record on challenging hospital mergers. We've challenged about 12.5 hospital mergers in the past 20 years and only lost 1. We've developed a very successful playbook for analyzing and challenging mergers involving hospitals that are head-to-head competitors. And that statistic I just mentioned, it does not include hospitals that have abandoned mergers after we've begun our review. It does not include mergers that state AGs were able to block using the playbook we put together on how to evaluate hospital mergers, nor does it include proposed hospital mergers that never made it out of the boardroom. But, and you did hear Zach mention this, despite all these wins we've had in court and all the progress we've made, we're still seeing rampant and concerning levels of concentration in healthcare markets. So our task in the enforcement community now is to identify these other drivers of consolidation and come up with the right analytical framework to understand and successfully challenge them. And there are a few drivers of consolidation beyond the traditional local hospital merger that we are seeing today and that we are scrutinizing. The first is on non-reportable deals. These are deals that fall below that HSR reporting threshold that Zach was mentioned. The current threshold is $111 million. So these deals are hard to detect since the parties don't have to tell us about them. But just because they're small, and by small I mean less than $111 million, that doesn't mean that these deals can't have significant impacts on their communities. And there are 2 different types of non-reportable deals that I want to focus on. The first is on what we call roll-ups. Now, traditionally, when we review a merger, we look at the single transaction that is being proposed. A roll-up, however, is a series of small acquisitions that, in isolation, any one of those transactions may not look concerning, but taken as a whole, the series of transactions lead to a quiet accumulation of concerningly high levels of market power. In the healthcare context, what we are seeing are health systems and private equity firms acquiring small independent medical practice through a series of acquisitions, a 30-person group here, a 5-person group there. Small acquisitions like this done over several years. Each acquisition, again, when viewed alone, may seem insignificant. And the FTC may not even find out about these transactions because they're so small and fly under the radar. But over time, those little acquisitions add up, and they can lead to highly concentrated markets where one health system or one provider group employs a significant number of physicians. And while the roll-ups are hard to detect, their effects can be very acute. We recently filed a lawsuit challenging a roll-up in the healthcare space. That suit was filed in Texas, challenging a roll-up in the anesthesia market by a national practice and its private equity sponsor. As the complaint alleges, the defendants in that case quietly acquired a number of small anesthesia practices in various cities in Texas, eventually amassing a dominant market share in those cities and using that market power to extract higher rates in those communities and throughout Texas as a whole. So another concern, that was one concern we had with sub-HSR transactions. Another concern with sub-HSR transactions is on what I want to describe as identifying and preventing catalyzing events. So when I say catalyzing events, what I mean is a transaction that serves as a flashpoint for a downward spiral towards consolidation. This is about stopping the snowball at the top of the mountain from ever becoming the avalanche. So an example of what I mean by this, in past merger reviews, we've seen situations of a proposed merger in a highly concentrated market, markets where there are 3 hospital systems and 2 of them want to merge. Under a straight legal and economic analysis, these mergers are highly problematic and illegal. The problem we face with some of these mergers is that the B side, the hospital that is being bought, is oftentimes a very distressed asset. It's a system that may be on the verge of bankruptcy and of shutting down. So blocking a merger does not always help the community. Concentration will increase whether the hospital is bought or whether it shuts down in bankruptcy. So the Problem is, by the time it gets to us, it's sometimes too late. Now, some of the things that we've seen when we're reviewing these mergers that fall into this fact pattern is that at some point, years before, one of the three systems, usually not the one that is currently in financial dire straits, but one of the systems engaged in a large but sub-HSR transaction, often a large provider group acquisition. And it was this transaction that started the downward spiral towards consolidation that culminated in a near bankrupt hospital and in a market with 2 to 3 hospitals in it. That group acquisition from years ago, that was the snowball at the top of the mountain. So part of our task here is to build out an early detection system to identify these smaller transactions and stop them before they lead to irreversibly concentrated markets. And there are things that we can do on this. You know, Zach said we need more funding. I will not say no to that. First, I hope Congress will give us more resources so that we can pursue more cases preemptively. Second, our partners at the state level, they have much more visibility and activity of the activity in their community. And they also have different laws on reporting healthcare transactions. So our state partners can and often do alert us to problematic acquisitions that don't rise to the HSR reporting level. And third, we encourage any knowledgeable market participants to flag transactions for us in real time. Now, these sub-HSR transactions, they're one issue, but we're also faced with kind of the opposite issue. We are also faced with mega mergers in healthcare. And as a general matter, the Commission finds out about these mergers before they're consummated because they're very big. And we do our best to investigate and challenge these troubling mega mergers. One challenge, though, is that 2 large hospital systems that are trying to merge may not actually have facilities in overlapping geographic markets and thus may not compete for the same patients. Some of the antitrust community have referred to these as cross-market mergers, and as you heard, that name may not be fully accurate. Now, if the merging parties don't actually compete at all in any capacity, then there are paths to blocking the merger are limited. But the problem here is that in the wake of these mega mergers or these so-called cross-market mergers, we see the undeniable effects of lost competition. We see rates go up, we see quality decrease, and we see services cut. So when we look at the effects of the merger, we know there is some loss of competition that's driving those effects, even when the merging hospitals aren't directly competing for the same patients. So what is that lost competition? It could be a dominant statewide employer or a payer trying to provide a health plan to all of its statewide employees or insurance enrollees, or it could be something else. So our task here is to better understand what's happening, to understand and identify all the dimensions of competition and the full extent of the commercial realities, not just the ones centered on local geographic area, so that we can prospectively analyze a so-called cross-market merger and block it before it results in harm. Now, another thing you've heard me mention is a focus on workers. Hospitals tend to be one of the largest employers in a community. And so we don't want to lose sight of any effects a merger may have on those who work at hospitals, for example, nurses. These are our unsung heroes in healthcare, and we want to make sure that a merger doesn't create a dominant employer that has the power to lower wages, lower benefits, or other working conditions. And it's obviously worth noting that overworked and underpaid hospital staff also have a direct impact on the quality of patient care. So making sure that our critical workers like nurses are protected and taken care of is important for them, but it's also important for patients. So evaluating labor impacts is a critical part of our hospital merger review. Now, I know I'm running a little past time and I want to just quickly wrap up. There are some other process developments in the pipeline that we also hope will help us combat consolidation in healthcare markets. The first is that the FTC and DOJ are revising our so-called merger guidelines. By way of background, the FTC and DOJ put out these guidelines that describe the analytical framework and the tools we use to evaluate mergers. The merger guidelines provide guidance to the public, to merging parties, and to the courts on how to assess the legality of mergers. And while they're not a law, they don't bind courts or judges. Judges do typically find them useful and have traditionally adopted their framework when litigating merger challenges. So we are in the process of revising our merger guidelines, which were last updated in 2010, to better reflect how we assess mergers today. The revised guidelines will provide more clarity on many of the issues we touched upon today, including evaluating the effects on workers, better articulating what the concentration thresholds are for a merger that's presumptively legal, and things like that. And we also proposed a revision to the form and the information the parties have to submit to the FTC and DOJ as part of their HSR filing. The goal here is for the agencies to get more of the critical information up front so that we can evaluate a merger early, and so we can more effectively assess and screen those mergers that raise concerns and not waste time reviewing mergers that are not problematic. And basically where I just want to leave it is that there's clearly a concerning trend towards consolidation and concentration in healthcare markets, and the FTC is committed to doing everything in our power to combat this trend. So thank you for the time.
Thank you so much, Rahul, for helping us understand all the efforts going on at the FTC to address consolidation. Next, we will move into a discussion on maintaining access to care and health equity, and we'll hear from Lois Utley, co-founder of Community Voices for Health System Accountability, a statewide alliance that is raising consumer voices as health systems propose mergers, acquisitions, new construction, downsizing, and closing of hospitals. Lois also teaches in the Master's Health Advocacy Program at Sarah Lawrence College. Lois has dedicated 25 years to protecting patients' rights and their access to care when health systems are consolidating, and we're so grateful Lois is here today. Lois?
Yes, thank you so much. I'm hoping you can hear me. Yes?
Yeah.
Okay, good. So thank you so much for the opportunity to say a few words about how hospital consolidation is affecting communities' access to care and health equity. I want to try to give you the view from the front lines at the community level. Next slide. So hospital consolidation is really changing the healthcare landscape for patients. Their community hospitals are joining large health systems that then shift decision-making to out-of-town executives. And often these executives look to eliminate what they view as duplicative services that can be found at other hospitals in the system. People are also seeing their community hospitals closing or downsizing. Hospitals are shutting maternity care, and they're closing or reducing the hours at hospital ERs. Next slide, please. As you've heard Zach and Rahul explain, increasing numbers of hospitals are joining health systems. The American Hospital Association, and this is their graphic, thank you, reports that there are now 407 health systems in the US, and that more than 2/3 of all hospitals belong to one of these systems. You know, being part of a large health system can seem very attractive to hospital boards and CEOs, particularly those struggling with financial issues. But often these mergers come with a big catch for the people who depend on the hospital for their medical care. Next slide, please. So I've worked with dozens of communities across the US where health systems have made big promises about the benefits of mergers or acquisitions. And here are three popular examples. They may say, the merger will stabilize your hospital financially and ensure it's still here for you in the future. They may say, the merger will improve the quality of care at your hospital. And you've just heard from Zach Cooper that that often is not a promise that's fulfilled. And third, your hospital will have access to capital needed to carry out renovations of aging buildings. Next slide, please. But once the merger goes through, those promises often are broken. And the post-merger effect can be like some of the examples I have here, where communities are then told, oh, we're closing maternity care, but you can just go to our other system hospital 25 miles away. Or the community may be told, we won't be allowing contraception, tubal ligations, abortion, or other reproductive health services that violate our system's religious directives. Or Often a private equity firm that's acquired a hospital may say, to achieve optimum efficiency and effectiveness, we need to cut the hospital staff by 25%. And sometimes the news is very dire. Unfortunately, we must close your hospital entirely. Now, sometimes it can take several years for the other shoe to drop in what I call the post-merger effect. For example, here in New York City, where I'm based, the Mount Sinai Health System took over Beth Israel Medical Center through a 2013 merger with the Continuum Health System. But 6 years later, in 2019, Mount Sinai tried to close Beth Israel. That plan fell apart when the pandemic hit and all available hospital capacity was needed. But now, Mount Sinai is back, planning to close Beth Israel and leave a large swath of downtown Manhattan with diminished hospital capacity. Thank you. Next slide. So who is harmed by hospital consolidation? As Zach Cooper has explained beautifully, hospital consolidation has often been shown to increase the price of healthcare, and that ends up increasing premiums and harming people with high deductibles, as well as people who are uninsured, and they can end up in medical debt as a result. But access to care and health equity are also harmed. People in rural areas can be left without ready access to medical care. People in low-income urban neighborhoods of color often feel abandoned by health systems that are closing their hospitals and instead moving into suburban areas where people have commercial health insurance. Women and other people capable of pregnancy can be forced to travel long distances for maternity care or suffer the loss of reproductive health services. These changes can pose real problems for people with disabilities and elderly people who cannot easily navigate changing health delivery systems, and also for LGBTQ+ people who often struggle to find healthcare providers they trust and then can lose them in these hospital changes. Next slide, please. So now I want to talk about an approach that one state, New York, where I'm based, has taken to try to introduce a health equity consideration into state review of proposed hospital consolidation. You know, when COVID-19 hit the state really hard in early 2020, I and some other health advocates, we raised concerns about how decades of hospital consolidation had left some communities without enough hospital beds. So former State Assembly Health Committee Chair Dick Gottfried and State Senate Health Committee Chair Gustavo Rivera sponsored a bill that was intended to introduce health equity into state review of hospital transactions through our state's Certificate of Need program. The measure was signed into law in December 2021 by Governor Kathy Hochul, and it then underwent an 18-month rulemaking period that engaged both health advocates and health facility representatives. And the law is being administered now by the State Department of Health's new Office of Health Equity and Human Rights. Now, let me just briefly tell you what the law requires. When a proposed health facility transaction would cause the elimination, reduction, or relocation of services, health facilities must hire an independent assessor to do an assessment of what's the likely impact of the change on medically underserved people. And you can see on the slide that medically underserved includes low income, uninsured, women, LGBTQ+ people, racial and ethnic minorities, immigrants, people with disabilities, rural residents, older adults. The assessor is supposed to conduct meaningful engagement of these folks and come up with the likely impact as well as a proposed mitigation plan to address any negative impacts. The assessor, by the way, is supposed to be independent have expertise in health equity, and no conflicts of interest, like an interest in approval of the transaction in question. Next slide, please. So the first test of this new law has been the proposed closing of the only maternity service in upstate Rensselaer County. That county used to have 3 hospitals with maternity services, but 2 of them were closed through successive rounds of hospital mergers. The surviving facility, called Samaritan Hospital, joined the St. Peter's Health Partners system, which is part of the National Trinity Catholic Health System. And because Trinity doesn't allow certain reproductive services, a separately incorporated hospital within a hospital was created to allow access to postpartum tubal ligations. That creative solution, however, fell apart in 2020 when Burdett was reabsorbed into Samaritan Hospital due to financial and staffing issues. So, okay, no reproductive services, but at least maternity care was still there. But then last spring, St. Peter's suddenly announced that it was closing the Burdett Birth Center entirely because it has been losing money. And the system said the pregnant patients could travel across the Hudson River to the system's hub hospital in Albany County. Next slide, please. There was a really strong outcry from the community, which would be losing its only maternity service. And by the way, that Burdett Center also serves people in several adjacent rural counties. Even the local Catholic bishop spoke out in opposition. Next slide, please. So how did the health equity law come into play? Well, St. Peter's filed its certificate of need to close the birth center 2 days before the new law went into effect. After considerable public criticism, St. Peter's reluctantly agreed to go ahead and commission a health equity assessment. They hired the Chartist Group, a national consulting firm that often advises hospitals and health systems, including Trinity Health, the parent system of St. Peter's. Next slide, please. A local coalition, the Save Burdett Birth Center Coalition, that includes midwives, doulas, and public health people, decided they would do their own health equity assessment following the model from the state. Frankly, they were mistrustful of what the study commissioned by St. Peter's would find. The coalition found that many people who have given birth at Burdett praised the midwife-led model of care and low rate of C-section deliveries. Black pregnant women, and you can see a quote from one of them on the slide here, said they feared the loss of Burdett, where they felt respected and listened to after many hurtful experiences with other health providers. And I should say that in Troy, where Burdett is located, many low-income people depend on having the birth center close by. Nearly 1/4 of the people in Troy live in poverty, and 22% of the households have no cars, and thus no way of going to another birth center. So there are also many rural residents who depend on Burdett. Next slide, please. So the Chartist Group did the health equity assessment, and many of its findings actually echoed what the community group had found in terms of health inequities and some significant transportation problems. However, in the mitigation section, Chartist then just accepted St. Peter's claims that it could arrange transportation for pregnant people and that patients could go to St. Peter's and use midwives there, even though only 16% of the births there are currently attended by midwives. At a forum the other night, the CEO of St. Peter's credited the health equity assessment as being helpful in identifying health equity issues. And he and the system said they would delay the planned closure of Burdett and engage the community. It remains to be seen, however, how robust that engagement will be and whether there are any ways to really mitigate the negative impact of closing the birth center. Wanted to just note that meanwhile, the State Attorney General, Letitia James, has also stepped in. She has regulatory authority over nonprofit charities, including St. Peter's Health Partners. So she's been looking closely at this closure. I want to flag that some other states are also looking at health equity in addition to price effects of competition, including Oregon and Minnesota. And as both Zach and Raul have noted, President Biden has said that hospital mergers are leaving many areas without good options for convenient and affordable healthcare service. So I'm eagerly anticipating the release of the FTC's new merger review guidelines and hope there can be some way to incorporate health equity concerns there. I'll just finish by flagging a few resources you can consult for more details about what I've discussed today. Thank you.
Thank you, Lois. Thank you to all of our speakers. I'll invite everyone to come back on camera and off mute for our last few minutes of discussion. The audience can continue to submit questions. We'll start out. We had a lot of questions come in, and I know a few of you touched on this, but can you expand on, what are the practical legal options for addressing already concentrated markets? Is any unwinding feasible? Do you anticipate, seeing more legislation in the states in the year ahead?
I mean, I think, yeah, I mean, I give my, so I think what the Massachusetts AG did, which is sort of say, if you merge, maybe we'll put some price caps on the merged entities, is sort of a really good start. I think unwinding is really, really tough. I think there's been, I think the Northwestern Evanston merger is the only one that I can recall. I think it might be worth looking into, but I think it's just very, very hard. I think it's worth considering price regulation. I think you just have to be exceptionally careful. I think our work pretty clearly shows that higher priced hospitals, if they face competition, have higher quality, and that may be potentially because their costs are higher. And so I think it's sort of assessing what's happening in those markets and looking at what's happening in some of the states and proceeding pretty cautiously.
Yeah, I just want to echo that. I mean, we definitely have within our authority the ability and the right to unwind an illegal transaction, but it's exceptionally difficult. It's very challenging. The metaphor often used is unscrambling eggs, which is an imperfect metaphor because we actually can unscramble it. It's just challenging. I will say, some of the other options like price caps and things like that, they're interesting. But I think one of the things that we need to be really sensitive to is it's really hard to change the incentives of the merging parties, and if they are incentivized to maximize profits, right? And the traditional way would be through price increases. Capping that just means they may be incentivized to find another way to eke out that profit, such as quality reductions or access issues. So our preference is obviously to prevent the consolidation before it happens, because the structural separation is the most secure way to ensure all the equities are at play are accounted for.
And one of the things we have to think about is, there's sort of breaking up existing firms, and we can think about that. The other is expanding the geographic scope of markets. So we're seeing evidence of patients being willing to travel farther in certain instances. I think the more that we can sort of make these markets bigger and potentially not expect that our local hospital can do everything for everyone, I think the more you're going to see competition in the existing markets.
Great. And I think all of you touched on this as well, but a few questions asking if you can expand on how consolidation is impacting the workforce, specifically nurse staffing, and how that's impacting patient care. And is that an area where we need more research, or is there enough research there to help show that?
I'll be really quick. So, but others, feel free to chime in. There has been a significant amount of research in the last few decades on labor markets, on labor economics specifically, which has really kind of revolutionized our understanding of how labor markets work. 50, 60 years ago, we would think of a consolidated labor market as a company town, right? Like Pullman, Illinois or something. And we now have a much more sophisticated understanding of that. And there is more research being done. But also taking just a step back, we do have experience looking at input markets in general. We do review mergers for buyer power. So we have the tools at our disposal, and it is something that we're very actively looking into. There was a merger that we challenged not too long ago, maybe a couple of years ago, where it was a time where we had a split commission where there was only 4 commissioners and not a 5th one. And this is public. Staff had recommended including a labor count into the hospital merger challenge. And all 4 commissioners were supportive of the idea of a labor count. It's just 2 didn't think that the facts supported it in that case. But it's part of all of our merger analysis. So.
I know we've mainly focused on hospitals today, but I know, Zach, you've pointed to some work on providers and physician groups. This question is, how do we deal with the concurrent horizontal acquisitions of physician groups, labs, clinics to steer referrals to the owner and not allow referrals elsewhere? And some health plans are seeing that.
Yeah, I mean, I think, so there's, again, separating vertical and horizontal. So we'll sort of take each in turn. The vertical stuff, I think the literature and the theory, or the sort of theory and the evidence is becoming much, much stronger. And, I'm doing some work on it. I know a lot of others are. I think, let's just say the theory for a second, which is, I as a hospital buy physicians, and those physicians then change their referral patterns. That potentially gives me more market power. It actually helps me as the hospital help those physicians negotiate higher prices. And I think we're starting to see evidence of both hospital and physician prices go up there. It's really challenging from an enforcement perspective because each of the individual transactions are small. I think Rahul talked about looking a little more into roll-ups, and I think it's something we need to seriously consider. I think the horizontal one, the theory is just sort of unambiguous in that case. I think it's hard in the physician sector because there are a lot of physicians, and 2 doctors or 10 doctors coming together, that's just a small transaction, and the agency has got its hands full already, and so it's like, how do you go after those? And the other thing we have to start thinking about is payers buying physician practices. I think that's another area where we need to study what's happening, think about the economics of it, and think about what impacts that has on prices, and whether it's leading to competitive advantage for certain firms via lessening of competition.
Yeah, sorry, Liz, go ahead.
Just quickly, from the patient perspective, when a health system buys a physician practice, one of the immediate impacts that patients see is that they sometimes encounter a facility fee. Being charged $150 extra to go see the same doctor in the same exact office they saw before. So that's something that is worth considering.
Yeah, and just to kind of I touched upon this a little bit in talks of what I described like a catalyzing event. Like that's what you're describing. That's what Zach is describing too. Is like these acquisition of these groups that change referral patterns in a way that causes a spiral towards consolidation. And the challenge there is definitely on the deal size. They're usually not over $111 million. But what we are seeing at the state level is that there are a number of states out there that are passing their own healthcare notification laws that have significantly lower thresholds and are just based upon different threshold metrics. Like in Washington state, it's based on provider size. So transactions that involve more than 7 providers have to be reported. And that's helping us, and working with the states in that way is helping build out a more robust early detection system so that we can, we have the authority to challenge the transactions if we know about them. So. And
just to build on, I think what the states are doing is vital. And I think what you're talking about disclosure requirements makes a ton of sense. I think the FTC has been really clear about some of the challenges that certificate of need groups can pose. So I think I'd be really cautious going down that lane. It actually often is a tool to protect the incumbents, but I think the states have a ton of ability to really support the federal agencies and do a lot of work on their own to make local markets competitive.
Great. Well, Thank you, Zach. We're going to make that the last word since we're right at 2 o'clock, but really want to thank our excellent panel of speakers. It was so interesting and helpful to hear about your work, your perspectives, and some potential solutions that our audience can take back to their work. Thank you to our audience for joining this discussion. Your feedback is important. Please take a moment to complete a brief survey that will open on your screen. And please check out our NIHCM's resources and research on consolidation and our other affordability related resources. And you can also register for our next webinar where we'll be talking about the growing combination drug use issue and the opioid crisis. So hope you'll all join us for that. And thank you again to our speakers so much.
Thank you.
Thanks, everybody.